What's the penalty for less than 30-day readmission? Where's the kick here? Who pays? What's the penalty?
The hospitals pay.
How much?
I don't know exactly how much, but there is a financial penalty for any patient who comes in for any reason after a heart failure hospitalization.
And the amazing thing is that for the 3 diagnoses that Medicare has designated, and these are Medicare penalties as areas of interest: heart failure, acute myocardial infarction, and pneumonia. If your rates of 30-day readmission are higher than expected, you pay penalties on your full Medicare budget. So, and those budgets are large, so the penalties are substantial.
Now, it seems to me that if there's this big financial penalty,
Yeah.
then the cost of a medication, if it's rational, which decreases the rate of 30-day readmission, should be bearable. The problem, it seems to me, is if the hospital's bearing the cost of the readmission, but the third-party payer is bearing the cost of the new medication, there's a disconnect, right? How do you fix that? Can you fix that? Anybody want to volunteer on this one? Or do we just let this go into the, we'll get to it.
Well, now you're shading into the realm of politics, which I
Yes.
suppose we shouldn't touch in these things. But,
Oh, go ahead.
But one way to do it is to create accountable care organizations where the payer and the provider are united in those incentives. And I think there are some reasons that you've outlined that makes sense.
All right, now you talked about putting some mechanisms in place to ensure that there's some continuity of care. And I was about to say the days of going to the patient's bedside saying, take your pills and have a nice life are gone, but I don't think that was ever an appropriate way to treat somebody leaving the hospital. So it should never have been there in the first place. So nurse practitioners, what else are the mechanisms? What other tools do we have to provide a transition of care to make sure folks get good care and don't come back into?
I mean, ideally, when the patient comes in on admission, he should be counseled. He or she should be counseled from day one. And that's an ideal situation. Whether hospitals have the staff to do it is a completely different question. But counseled on day 1, counseled on day 2, 3, however long they're in the hospital, just to make sure that the patient gets repeated consultation. And therefore, they're not getting counseled on the medication for the first time at the point of discharge, where they're not going to remember anything. So that's an ideal situation. Whether it happens in reality is completely different.
Is it happening in reality, in the real world out there? Are patients getting seen? Are treatment care plans being reviewed? I heard a snort to that.
I mean, we're all trying. I think there's the ideal, and then there's the practical, and I think sometimes we can't catch patients as quickly as we should, to use your analogy. I think, but we're all striving to provide mechanisms for early post-discharge follow-up for patients, for routinized discharge instructions that meet all the metrics that we've talked about, that provide patients with some guidance about who to call, when to call, and what to look out for. And I think that when we do that well, then patients do tend to stay out of the hospital.
Now, Sheryl, you were telling me actually that if a patient is sent home on a medication, if I heard you correctly, they're more likely to stay on it than if it was added later. Is that true?
That's correct. So there was a study, Optimize, that looked at patients that continued onto medications, continued with their medications out to discharge. And it was found to be that those doses and those medications were continued on. So it really is a teachable moment for the patient. It's also the best time to initiate, assuming that the patient is stable, of course, but it's the best time to initiate the proper doses of medications and the proper medications based upon the guidelines, if you can at that point.
Peter, I think you also bring up another important point, which is that we in the cardiology specialties are not the only people taking care of these patients.
Right.
So they're going out and they're seeing their primary care physicians, their internists, more than they see us for the most part, or sometimes more than they see us. And it's really important for these folks to be knowledgeable about some of the new medications. And I think that's why we're doing this program, for sure. More and more primary care physicians are actually seeing patients on drugs like sacubitril/valsartan, are initiating therapy with drugs like this. And it's important that these not be considered cardiology-only pharmacologic therapy.
Well, first of all, cardiologists, there aren't enough cardiologists to take care of everybody day by day out in the real world. And I sometimes, when I think about primary care, I can't believe these people are doing the job they're doing. There's everything coming through their door. And all these new medications, some of which are completely unfamiliar, are showing up on their doorstep. So what can we do, other than this broadcast, to help primary care docs take care of the patients with heart failure that we're sending out on these novel agents like ARNIs? Should every patient going out, for example, get a phone call to his or her primary care on the way out the door and say, look, I'm sending you Mr. Jones or Miss Jones, and there's a new drug, I can tell you about it?
Well, it'd be nice if we can do that, and many of us do call the referring physicians when we discharge patients. We dictate or write letters to these doctors also to tell them about the medications we're using, and I think in the cases of using a novel medication that they may not be familiar with, it is part of our job to educate them about it.
No, and I completely agree. I mean, a lot of PMDs will receive the New York Heart Association Class 2 and 3 patient, sometimes 2 before the cardiologist even follows up with them. And therefore, PMDs feel comfortable starting an ACE inhibitor in a patient with HFrEF. Why not start an ARNI? Just because it's a new medication, I understand that often there's some discomfort. But it is guideline recommended and strongly supported.
Is there something, anything, that let me turn this around again, that a PMD can do to help us, not me particularly, you guys, to make this process seamless?
I think there's a lot. The first thing I'd say is that the best strategy for heart failure management, even in this day and age with better medications, is prevention. And so the first thing the primary care doctor can do is understand the underpinnings of heart failure and help us prevent it, right? So that aggressive treatment of blood pressure, aggressive treatment of diabetes, aggressive treatment of coronary disease, these are the things that help us not have to deal with the application of complex medical therapy. But then beyond that, I think helping patients understand the importance, once the medicines are prescribed, of adhering to the medications, the rationale for continuing therapy even when you feel well, and recognizing the symptoms and the adverse effects that might be related to the medicine so that they can help them manage the disease over time.